This is an interview with Dr. David Sencer, former director of the CDC, about the Smallpox Eradication Program in the 1960s. The interview is being done at the CDC during the 40th anniversary of the launch of the Smallpox Eradication Program. It is July 7th, 2006, and the interviewer is Victoria Harden. Now, Dr. Sencer, before we get to smallpox, I'd like to establish who you were in 1966 as the director of the CDC who had to manage the overall direction of this program. I want briefly to go through your background. Now, I know you were born in Grand Rapids, Michigan on November 10th, 1924. And I would ask you to begin with to describe a little bit about your growing up and your pre-college education.
I don't remember very much about the early years. My father died when I was 4, and my mother, this was in 1929, just at the beginning of the Depression, and my mother had to go to work, and so I was an only child in an empty house, and sort of from the beginning had to fend for myself. I went to elementary school in Grand Rapids, and then started high school in Grand Rapids, but my mother felt that I be in an environment where there were more men rather than just with a lonely widow, and encouraged me to apply for a scholarship to a boarding school outside Detroit, Cranbrook School, and which I obtained a scholarship. My mother had to pay $32 a month, which in 1936 was quite a burden on her. But I ended up going to boarding school there for 5 years. I got I think a very good basic education, and did get into an environment which was much more masculine than being home with my mother.
At that time, did you have any notion of what you wanted to do for a career?
When I was in high school, the things that really interested me were the sciences, biology, history, geology. I was more interested in the sciences than I was in the softer things.
When you went to Wesleyan for your college education, this was in the middle of the war, in 1942. Tell me about going to college at this time and how this prepared you for medical school.
Actually, it's the beginning of the war, 1942, not the middle.
Yes, the beginning. You're correct.
Actually, the first year was just sort of a normal undergraduate year. There wasn't the pressure on to hurry up your education. There wasn't the draft wasn't threatening. So I took a sort of a normal liberal arts course with English and German and history, and one course in biology. And then the pressures began to build, and the military had a variety of programs, V-12 in the Navy and ASTP in the Army, where college students could be actually enrolled in the military, paid a small stipend as a able-bodied seaman or private, continue their college education, and with the idea that they would then become officers in the military. I was in the V-12 at Wesleyan, and by that time I had decided that putting my various interests together, medical school would be the best start. I had ideas at that time of getting into biomedical research. We didn't call it at that time, but that was sort of my goal. But I suddenly found that I had to accelerate my program, and I ended up taking organic chemistry first thing in the morning, inorganic chemistry, which was the introduction to organic chemistry, the second thing in the day, plus physics. And the only thing that I could find to fill out my schedule were 2 courses in German literature. And so I struggled through that year of a very heavy classroom load and got all of my pre-med credits out of the way. And then they said, you've got your pre-med credits, you've got to leave because you finished. And he said, there's no room in medical school, so we're going to send you to boot camp in the Navy. And so...
Let me interrupt you just for
Sure.
one moment before we go forward. You said you had determined that going into medicine was going to be what you did. How did you get there? Was there anybody who pushed you, or
No.
you...
No, it was just sort of a bringing together of various interests, and I really, there's no role model or anybody that did that. It was just, that's the way I just sort of evolved in my own thinking. So I went to boot camp and learned close order drill and how to evacuate a lifeboat and climbed ropes and things like that, and then became a hospital corpsman, pharmacist mate it was called at that time. I was at Mare Island Naval Hospital, and then at the Naval Hospital at Camp Pendleton in the middle of the Marines. One day somebody came by and said, do you want to go to medical school? And my name was also on a list to be transferred to the Marine Corps, and I said, I have a choice between the Marines and medical school. They said, yeah. I said, I'll go to medical school. And it ended up that I went to a 2-year medical school initially at the University of Mississippi in Oxford, Mississippi. I was in a class of 27 people, and then after finished my 2 years there, I transferred to the University of Michigan to finish my medical education. Soon after I got to Ann Arbor, a routine chest x-ray showed that I had minimal tuberculosis, and I was hospitalized at the University Hospital for a year. This was before drugs were routinely used, and tuberculosis at that time was being treated with bed rest. And in Ann Arbor, when they said bed rest, that's what they meant. The complete works, bedpans, meals in bed. If you, once a month, you would roll out of bed onto a stretcher. They'd weigh the stretcher and you. When you got out of bed finally after a year, you sort of collapsed on the floor because your knees weren't very used to carrying that pressure.
What did you do all that year? Did you read?
Yeah, this was one of the, I read and listened to the radio. I read the New York Times. I read Harper's. I read the Atlantic Monthly. I read Saturday Review of Literature. The one rule that they had was that they didn't care what you read as long as it had nothing to do with what you were going to do. I read no medicine, no journals, but this was good because it opened up a whole new variety of things to me that, when you've been in this grind of doing your pre-med and medical school, you don't have time to realize that there is a world outside yourself, outside of science. And the radio, I had an FM radio. In those days, that was something. And I could get political broadcasts, a town meeting of the air, and things that got me interested in politics. And it was I guess it's what you call a life-changing interlude. I won't say I enjoyed it, but it was probably the best thing that happened to me.
Would you say this had a lot to do with your interest in worldwide public health and doing medicine?
I think it planted seeds. I don't think that, I wouldn't say I immediately became an advocate of this or that, but it did plant the seeds and give me some background in things other than science and medicine. Went back to medical school, finished going to school. I was on a part-time basis. They were very cautious about tuberculosis in those days. And I finally finished up in January or December of 1951. I have the distinction of being the first in my class and the last. I was a class of one, and so if I want to brag, I can do it. If I want to poor mouth, I can do that too. And by that time, I'd met my wife before I went into the hospital, and after I got out, we got engaged and got married. And I started my internship in Ann Arbor, and rotating internship in medicine, and went on with what we called residencies in those days, a fellowship nowadays, but in internal medicine for about a year and a half. And then one day on grand rounds, the chief of medicine said to me, he said, "Sencer," he said, "you know the military's looking for you?" I said, "Well, no." I said, "I'm 4F." And he said, "Not anymore." He said, "They say you're 1A, and they want you." They wrote and asked if you were essential, and I told them the department would fall apart for exactly 2 minutes if you left. So by this time, we were expecting a baby, and we had to move out of our apartment because there's no pets or children. And so here I was, do I get another apartment? What do I do? I went to the Navy. I figured I'll go back and re-enlist, and they said, "Not with your medical history, but when you're drafted, we'll be glad to have you in our quota." And I thought that was a terrible way to do business. And I was at a concert in Ann Arbor one night, and I saw a friend of mine who was a professor of public health, Cy Axelrod, telling him my problems. And he said, "Join the public health service." I said, "What's that?" And he said, "They've got a tuberculosis research program, and you could get into that." So I wrote the public health service, and they said I want to come in the tuberculosis program, and they kept saying, "Well, why?" And I said, "I don't, you know, what I want to know is when." And so I finally, in January of '55, I became a public health service officer in the tuberculosis program.
We shouldn't talk hypotheticals, but do you think you would have stayed in internal medicine and gone into practice had you not done this?
I had a subspecialty in mind in chest disease, and yeah, we liked Ann Arbor, and we thought, I'll just go on and stay on at the university and so on.
But instead, you joined the public health service and began to work in tuberculosis and the migrant health.
I started off sitting around in Washington. They really didn't know what to do with me, and I was acting as a code clerk on some research projects in tuberculosis. And then one day they said, "We're sending you to Idaho to run a survey of the health status of migrant labor." And so off to Idaho I went, and I got there and found that we had a little caravan of 2 house trailers to use as examining rooms, a mobile x-ray truck, and a mobile laboratory. And we were to go to these labor around the Snake River Valley. I learned how to drive a car with a trailer attached to it, and we'd go into a labor camp and hook up the water and talk with them about coming in for examinations and so on. And several things began happening at that time that sort of changed my whole attitudes. Began seeing people who were disenfranchised. These were people who claimed to be from Eagle Pass or far Texas, but you knew very well they were from the other side of the border. They'd come to Idaho for 6 months. They would not get citizenship in that 6 months, and so they had no rights in Idaho. The farmers weren't interested in paying them anything more than the minimum wage, and there were no health insurance, and we began to get into some real problems. We didn't see much in disease. They were actually a fairly healthy group. They wouldn't be working in the fields 12 hours a day. But we did find a a young man who had a tuberculosis of the knee. Well, Idaho had agreed to accept people in the hospital if they had infectious tuberculosis, but he didn't have infectious tuberculosis, and so how do we get him treatment? Well, we convinced him he was under 18. He was 20. But if he was under 18, he would qualify for Crippled Children's Services, which was a federally funded service. And by subterfuge, we were able to get him treated for his tuberculosis. And then a few days later, we found a young girl who had far advanced tuberculosis, a 12-year-old, hospital in one of the towns, and the hospital administrator called and said, "Get her out of here." And so I went to see her parents, and I said, "Don't visit your daughter, because if you do, they'll make you take her home." And we made arrangements to transfer her to the tuberculosis hospital, about 100 miles away. But she had to have 2 pairs of pajamas and a toothbrush. Well, pajamas, what are they? So I said, you know, let's see what we can do. I went to the TB Association. They said, she doesn't buy Christmas seals. Went to the Latter-day Saints. This is a big Mormon area. She's not one of ours. I went to the Catholic Church, and the priest said, you know, they never baptize them down there in the valley, but he gave me $10, and I gave it back to him. There was a small community of Quakers outside of town, and I went out and met with their elders, and they said, come back at 6 o'clock. And I went back at 6 o'clock, and here's a whole pile of clothes and so on. So I thought, oh boy, this is an opportunity to talk to them about problems with the migrants. They wanted to talk about the fact they were playing baseball on Sunday in Boise, and that was bad. But these things like this got me interested in public health, that this was a way in which you could do more for groups of people than just for the individual. And so I really began thinking of it as a career change. And then I got a letter saying you're being transferred to Columbus, Georgia to run the tuberculosis research station there, and which seemed great. And we went there. My wife's first experience in the South, and Columbus was really South at that time, and we were not a bit happy. But I had a wonderful job, and then they sent me to School of Public Health at Harvard, you know, it was necessary to get a union card. I don't think I learned too much at Harvard, except from the other students. This was much more important to me than many of the courses that I took. I went back to Columbus for a year, and then transferred to Washington to a job that I thought was just terrible, but I realized that it was a very excellent opportunity to learn how things really happen in Washington. I was in the bureau chief's office as a gopher, but I learned about the budget process. I learned about interagency problems, and I learned, you know, how things really transpired. And then in 1960, I was transferred to CDC as the assistant chief, and I fell in love with an agency.
This is what I understand. In Elizabeth Etheridge's history of the CDC, she says you always thought this was the best job in the world to be director of CDC.
Absolutely.
So obviously your mind had shifted. You were ready for public health, and you had this training that served you in very good stead as to how the bureaucracy. Walk me through now your rise through CDC until we get to the beginning of the smallpox program.
For the first 2 years, I was the assistant director. Larry Smith was the director, and I did. Again, it was a learning process about CDC. One of the things that I did, I won't say I read, but I scanned all of the articles that were for public. I got copies of everything that the print shop did, just as a way of getting familiar with the total activities of CDC. During that period of time, there was one thing that we did that I was an intimately part of. Oral polio vaccine was about to be licensed, and the Public Health Service in 1955, when the inactivated vaccine was licensed, had bought up all of the vaccine and distributed it to the states. Well, they didn't give them any money to help organize programs. The easiest thing to do was just to give it to school-age children. And so we saw a change in polio back towards infantile paralysis. It had been gradually becoming a disease more of older children and young adults. Suddenly, because the school-age kids were getting vaccinated, it was the young children before they got to school that were getting polio, and they were those people living in the inner cities and the low-income groups who couldn't afford pediatricians who would give it to them. And so you had outbreaks of polio in the late 50s and early 60s in Kansas City and Chicago and places like this, all concentrated in the inner cities. When oral polio vaccine was on the horizon, the Surgeon General's public affairs officer, J. Stewart Hunter, said, let's buy up all the oral polio vaccine and distribute it. And we said, bad idea, bad idea. And we wrote a piece of legislation that said that the Public Health Service would provide vaccines, not just polio, but vaccines to state and health departments. And this vaccine could be used for children under 5. But we also said there will also be money for the states to organize programs to immunize the children. So we changed it from just being concerned about polio to being concerned really about a better public health approach of generalized immunization against not only polio, but diphtheria, tetanus, and whooping cough. And that became the basic legislation for a long time when they added measles and German measles and whooping cough and chickenpox to this. Between 1963 and 64 and 66, I was a deputy director under Jim Goddard. Jim was a wonderful guy. He was gung-ho, do everything. And after about 6 months, Jim said, you know, I'm in the wrong job. He said, I need to be in a small agency that needs to grow or an agency that's in real trouble and needs to be fixed. And CDC's neither. And so Jim began doing other things, and I was doing the day-to-day management of CDC during that period of time. Then in 66, Jim got transferred to the Food and Drug Administration, which was an agency that was in great trouble at that time and still is. And I became the director in 1966. At the same time I became director, AID transferred the Malaria Eradication Program to CDC, which was really in great trouble. Malaria eradication was failing. It was based on some premises that weren't working. Suddenly CDC had the responsibility for a program that was failing. We also suddenly inherited staff in 16 different countries, and we had to payroll them out of CDC, and it was a great problem. Actually, CDC was the biggest employer of people in Haiti. The whole malaria eradication program was a direct CDC hire. And we could just see this whole malaria eradication program one day marching down the streets and part of the political uproar in Haiti. But we, over time, not in 1966, but over time, we were able to bring about major changes in the malaria program across the world. It meant working with WHO to get off the concept of eradication, begin to look at control and prevention of death in children. Then in 66, later in 1966, the smallpox program started. Actually, it goes back before that.
All right, it goes back before that.
Yeah. Let me try and reconstruct the history as best I can remember it. And I'll talk about CDC's involvement in smallpox, not the whole bit. Alex Langmuir, who is the director of epidemiology at CDC, had, back during World War II, had been very interested in biological warfare, and it was on the basis of the threat of biological warfare during the Korean War that the Epidemic Intelligence Service was formed. One day in Congress, they asked Dr. Justin Andrews, who was the director of CDC at that time, what are you going to do about biological warfare? And Justin thought real quickly on his feet, and he said, well, now that we can use the draft, we're going to establish an epidemiology service of young people that we will train to recognize abnormal occurrences and help us have early warning against biological warfare. And that was the beginning of the EIS. Alex, of course, had been plotting this along the way, but here was an opportunity to do it. He had had a basic interest in smallpox for a long period of time, and he got Dr. D.A. Henderson, Donald Henderson, interested in smallpox. I think it was in '62, Don Millar, as an EIS officer, was sent to Indonesia as a malaria assessment program, but he, for the first time, saw smallpox. Became very interested in the disease, and when he came back, surreptitiously carrying some scabs of smallpox for the lab, he was put in charge of what was called smallpox surveillance in the epidemiology program. He was it. There wasn't anything else. But they began talking about, you know, is this a disease that could be eradicated? In contrast to malaria, where you have a mosquito vector, where you have animal hosts as well as human hosts, smallpox is directly transmitted from people to people and has no animal reservoir, which makes it, and we had a good vaccine, which made it susceptible to eradication. The military had invented a jet injection which would give rapid vaccination for large numbers of people. CDC helped them change this so that they could give intradermal injections, smallpox vaccine being given intradermally. This was tried out in Tonga, in the friendly islands of Tonga, and everybody jokes about why they picked Tonga, and our audiovisual group here at CDC made a beautiful movie of this called Miracle at Tonga, with the waves crashing up on the scene. But Tonga was an area that had never had smallpox, and there had never been any vaccination, so it was a virgin territory to try out vaccinating people with a jet injector, and it worked very well. In 1965, after a couple of years in Geneva, the WHO, the World Health Assembly of WHO, passed a resolution calling for the worldwide eradication of smallpox, and Lyndon Johnson issued a statement saying the United States would support this and contribute to the effort.
Can I get you to stop and say, was there more to getting these resolutions issued?
Yes. I had nothing to do with that. I was not involved with that. That was really Alex and D.A. Henderson, who worked with Jim Watt, who was the Director of International Health for the Public Health Service. They really worked the streets of Geneva to get this done, and they deserve a lot of credit for this. It was a lot of hard political horse trading. The Indians were against it. Everybody who had been burned by smallpox or by malaria eradication says, oh, no. But during this period of time, D.A. Henderson had become quite familiar with WHO, and they had become quite familiar with DA, which I think is important as we go on. So that this was a lot of hard political work being done. I got a phone call. Jim Goddard was out of town. I got a phone call one day in 1965 from Dr. A.C. Curtis, who was in the African Bureau of USAID. And he said, how would CDC like to take on a measles eradication program in West Africa? Before this, Dr. Harry Meyer at NIH in the old Division of Biologic Standards had instrumental in developing measles vaccines and was testing out different strains of measles vaccine in large populations. And measles was a terrible disease in Africa with high mortality in children. It was a real killer. And so many of the field trials that Dr. Meyer was involved in were done in West Africa, and the measles vaccine was tremendous. And so AID looked at this as should we now move in and try and make a bigger program? I told Dr. Curtis that we were not interested in measles eradication because measles eradication was not feasible, but that measles control might be feasible and CDC would be interested if we could couple it with smallpox eradication. And he said, sure. It was as simple as that. So again, the hard work of negotiating agreements with AID, writing what they call PROAGs and all sorts of documents that had to be written about each country, getting each country agreement with it. Dr. Henry Gelfand on CDC staff spent lots of time going from country to country, getting country agreements, getting things signed, trying to recruit people to become part of the program. All of this was happening in late 1965 and early 1966. Finally, all of the paperwork was done. AID had agreed to fund it. We had a 5-year agreement with AID, and the program was to start on July 1st, 1966. DA was a good friend of mine and of the family, and his daughter and our oldest daughter were very close friends. They were in the same grade in school. And his daughter kept telling my daughter, you know, we're going to go to Geneva in November. And I'd speak to DA, oh no, I'm not going to, I don't want to do, no, I want to stay here and run the program. Oh no. And Lee was saying, you know, we're getting ready to leave in November. And DA, no. And finally he said, well, I was ordered to do it. Well, you know, his mouth was drooling to do this. And so about this time, he transferred to Geneva, and Don Millar was appointed head of the program. Don had been off at the London School of Tropical Medicine for a year. He'd gone there because there were people in England were very much interested in smallpox, and he could get some additional experience and training there. You'll be interviewing Dr. Millar, I'm sure, and you might want to ask him about his dissertation at the London School. I'll let him tell the story. But he'd come back now, and he was a logical one to head it up. Well, in the early part of 1966, this was being run out of the epidemiology program, and they were pretty provincial in some ways. They thought that epidemiologists were the solution to everything, and that's all they needed. Well, you know, if you're going to run a big program like this, it's going to take more than just epidemiologists. So we sort of forced a public health advisor on the program. you'll be interviewing Billy Griggs this morning, I think, and so we pushed Billy Griggs into the program to be a deputy to D.A. Henderson to help with the nitty-gritty of organizing and paperwork and so on. And by doing that, as they began staffing up for the West African program, Billy made sure that there was also something called an operations officer with each of the epidemiologists, somebody who would take care of the logistics and all of the things that had to be done, and you'll be talking with many of those.
I am, but I'm interested in you as the director. What made you buy that idea? Was it the time that you had spent with the migrants and realized just how much the operations involved?
You know,
because
when I came
you're
to
a physician too.
Yeah, sure. When I first came to CDC, there was an older man. He's 9 days older than I am, by the name of Bill Watson, who had been in the venereal disease program for a good number of years, and it had been transferred to CDC. Larry Smith was the director of CDC at that time, and he'd been the director of the VD program, and he knew Bill's capabilities, and he had moved Bill out of the VD program into the front office. He was the assistant executive officer at that time, and I got to know Bill very well, and actually he was our best friend here in town, and he would tell all these stories about how the VD investigators worked and so on. I began seeing how this was a very key part of disease control programs. People who would get out in the field, knock on doors, talk to people, understand how people went. Their first assignments usually were to local health departments, where literally that's what they did, was to track down contacts of cases of syphilis and gonorrhea, try and bring them to treatment. Then they would, after a couple of years of that, they'd become a supervisor with responsibility for several other people.
And they weren't physicians.
Oh no, this was a group of people that were recruited usually at the baccalaureate level, not disappointed pre-meds, but people who were interested in people. And there were certain schools that they went to recruit because they knew these the sorts of people that they wanted. They would move up sort of in a supervisory managerial chain and always be behind the physician. And in the state health department, there would always be a senior public health service, a public health advisor behind the state VD control officer who pushed, push. Never makes a decision, but push the physician to make the decisions and take the leadership role. And they learned this very, very well. This is how you get things done. You don't have to make the decisions yourself, but you get somebody else to make the right decision.
That's very interesting.
Yeah, and they're actually, they've been writing a history of the public health advisors that you might want to get a copy of. I think they're looking for a publisher. We broke our chain of thought there.
Sorry. You were pulling together, getting these various types of people, and how much of it did you do and how much did you delegate? What did you look for in your staff here to run this program?
I looked for Billy Griggs to make good personnel decisions. The physicians had already been pretty much recruited by DA. We lost a few the first year in training that were real misfits. But many of them were EIS officers. Others had not. Well, Stan Foster, for example, had been an EIS officer, had left and was back in residency training, and DA called him and said, "You want to go to Africa?" And Stan said, "Sure," and he came back to CDC. Rafe Henderson, who going to be the regional epidemiologist, had been at CDC for quite some time, had been on some of the early trips to West Africa. Um, and Rafe had very good sense about people too. So you know, I think we put our trust in the people who were running the program because we knew Billy Griggs was good, we knew Don Millar was good, we knew DA was charismatic and a great stimulator. Um, not the best manager while he was here. He developed some excellent management techniques as he went on and so on. But you know, we knew what was going on, but we kept out of it. You know, you get good people to run something, and then you let them. When
did you make your first trip to Africa?
In the smallpox program, I think my first trip was for the 25th million. They had a big celebration in Ghana in 1968
Yes.
To celebrate the 25 million vaccination that was given, and this was a great PR opportunity. USAID thought it was wonderful, and the ambassadors were there, and Jim Lewis, who you'll be interviewing later, was the operations officer in Ghana, and he had done most of the arrangements for this great to-do. It was out in the country about 90 miles north of Accra. Tribal chiefs in uniforms with umbrellas and gold robes and dancing and so on. And things like this were called durbars. And I remember the American ambassador just shaking his head. He said, you know, I've been to a 12-chief durbar, but this is the first time I've ever been to an 18-chief durbar. But the Surgeon General was there and gave the 25 millionth vaccination to a screaming little girl. And then after that, while we were there, they had also recruited a reporter from the New York Times, Fred Friendly's son. And they had the military attaches, DC-3 from the embassy in Dakar. And the next day we flew for breakfast from Dakar to Abidjan, had breakfast at the airport with the Minister of Health and the ambassador, flew to Monrovia in Liberia for lunch with the Minister of Health and the ambassador, and to Freetown, Sierra Leone for dinner.
Wow.
We refer to that as breakfast in Abidjan. But it was good public relations. It showed the Surgeon General was with us. It showed support from the top. It was, it reinforced the USAID too, the importance that we gave to the program, that we could get the Surgeon General to participate and so on. And then from Sierra Leone, we flew to Bamako in Mali, and the pilot had never been there, and so our route, he flew east until we found the Niger River, and then he just followed the river up to Bamako. Mali at that time was a Marxist country with mostly Chinese there. It was Chinese construction, Chinese this, Chinese that, Chinese all over the place. And we spent some time in Bamako and then flew out to a market town and then took the Dodge trucks out to the Dogon territory. This is sort of the end of nowhere, out with cliffs that fall off into the sub-Saharan plateau. And the Dogons are the people who had these big masks, and they had dancing and thousands and thousands of people getting vaccinated and very colorful. And there was a missionary there who we stayed with. He'd been out 40 years. 10 years out, 2 years back, 10 years out, 2 years back. And sleeping under the stars, where there were no lights. It was a wonderful experience. And the next day we flew to Timbuktu, and then went on through Niger, Togo, Dahomey, and back to Lagos and home. So I went to Africa. I wasn't running it.
Well, see, that's important. We got to get all this.
Yeah.
But you were the person in the middle between the program and some of the other bureaucracy. And it actually, when you went to Congress,
We didn't have to go to Congress. AID went to Congress.
that's right. But was it not on your shoulders in the sense that this was CDC people, the director?
Sure, but the way CDC ran in those days, you get the right people and then you get out of their way.
I'm with you 100%. Okay, are we ready to roll? Or
I am rolling.
I'm sorry.
But,
Sencer,
even in those days, I was known for walking around.
Yes.
And I knew what was happening. I would ask questions. It scared people sometimes. There's one person, I walk in every time he was reading his paperback. Finally, he didn't even put it in his desk drawer when I'd come in. But anyway, let's go.
I did want to mention, if you
Oh, did I do something?
don't hit the mic, that's all. Just be aware when you use your hands.
Yeah. I've been good so far.
Yes?
Yes, you have.
Yes.
It's been a good boy.
All right. I would like to pick up with what you were doing in the program back here in terms of could you say a little more about the relationship, the bureaucratic relationship of the program to Department of Health and Human Services, Public Health Service, and AID, and what have you?
Actually, in this part of the smallpox program, the West African program is pretty self-contained as far as budget and management was concerned, because we had our money from USAID. Billy Griggs would handle most of the dealings with AID on paperwork and so on. And we really did not, at the front office level, have too much problems with it. It was, it was something that we knew about on a day-to-day basis. It was not something that gave us real problems. We had good leadership, and it was, again, our philosophy is you get good people and let them do the work. And
What was the toughest problem that you faced?
during the African program, most of the problems Billy handled. You'll ask him about that, because the toughest problems were paperwork and things like that. Our real problems with smallpox began after the African program. The one thing that the African program did was the demonstration that mass vaccination was not the way to go in smallpox eradication. The story of you'll get Bill to tell it himself, but Bill Fagey was working as a medical missionary in eastern Nigeria. He was volunteering as being the smallpox epidemiologist for that area. He did not have enough money for, he did not have enough vaccine for the mass vaccination program, and he began looking at the spot maps of how smallpox was moving from village to village and how long it took to move from village to village. And he said, if we could prevent it from moving from one village to the next, maybe we could break the chain of transmission. And so he developed schemes of getting village leaders to tell them when there was smallpox, and they would get in and vaccinate that village and around it, the contacts, to contain it. And suddenly, smallpox in his area began disappearing. He hit it at the low point in the low point in transmission, so he was able to get to all of the foci of smallpox, and smallpox disappeared from his area. This was presented in a variety of ways, and finally they said, well, let's see if it really works on a big scale. And they went to Sierra Leone, where Don Hopkins was the medical officer, and Jim Thornton, Sierra Leone, was the operations officer. Sierra Leone had the highest rates of smallpox in Africa, and was as backward as they come. They knocked out smallpox in months, and then it was adopted for the whole West African program.
What was the problem with, not problem, but what was the mechanism for telling everybody we're changing the way we're doing this, and what convinced you?
You know, this is a scientific, you know, here's the data, and you know, they did it. I didn't have anything to do with it. You know, we said, yeah, you know, you got the information, go do it.
But I understand this was not always the case in the World Health Organization and other places.
Yeah, WHO was reluctant to accept this. They'd been selling the concept of mass vaccination, and they were reluctant to begin talking about this because they'd sold the countries on mass vaccination, and now they had to go back and re-educate them. And again, this was really more after the West African program that this had to be done. DA finally accepted that this was the way to go, but it was really after the African program that the hard work began, and this is another story of India and Bangladesh and so on.
Well, and I remember that once you had gotten to zero pox in West Africa and had finished the program, the CDC was no longer getting funding from USAID, but you didn't want to let the program completely die, so you could continue surveillance, as I recall, and you appointed Bill Foege to be head of the Smallpox Eradication Program. Can you talk about the sort of the follow-up from CDC to the West African program there?
Trying to think. When we reached zero in West Africa, Bill came back. He came back, and Don was still in charge of the program for a while. And the International Red Cross called and said that they were getting concerned about the famine in West Africa as a result of the Nigerian war, and asked if Bill Foege, asked him by name, would come and do a surveillance of how bad the famine was. And Bill went, and his wife was very reluctant to have him go because she knew if he went, he might not come back. He would just want to stay and see things through. But he went out and developed a surveillance technique for this, and then we began feeding CDC people in to maintain the surveillance activities and identify where the famine was worse so that relief activities could get into it. This was CDC money at this point, but we were doing it under the guise of protecting this country from the possibility of recrudescence of smallpox and so on. And some of the travel was being paid for by USAID. We were paying all the salaries. And then the State Department began getting worried about what was happening in Biafra, the secessionist state, and asked if we would send somebody in to do a rapid assessment. Well, Carl Western, who had been at CDC for a good number of years, agreed to go, and he was taken out to one of the islands off of Nigeria and flown in at night to Biafra we had no official presence in Biafra. And Carl did a magnificent job of showing that the famine was the worst famine that had occurred since the potato famine in Holland after the war, but that it was localized, and that what was happening is that the relief activity was getting in and would set up in a village, and then all of the relief activities would come in competition. You'd get the Lutherans, you'd get the Catholics, you'd get the World Fam, Oxfam, and so on. So some villages were getting all of the aid, but the major part of the country was not getting it. They were getting it where it was easy to get to and not out into the bush. As a result of that, I got a call one night from Jesse Steinfeld, the Surgeon General, and he said, "You and Western get to town right now." And we went up and we went to the White House on a snowy January night and went into the Situation Room at the White House, and who should show up but Henry Kissinger. And so suddenly we were briefing Henry Kissinger on this. He was a national security advisor. And in typical Kissinger fashion, he was playing USAID, who was saying there's no problem in Biafra, against the State Department, who was saying there was a problem in Biafra. And he was just enjoying it. I mean, he didn't give a hoot about the famine. It was the bureaucratic struggle. And we had to brief the State Department person who was going to Congress the next day, and he kept referring, one of the major signs of nutrition is edema of the legs, and that was a quick way of determining how bad the famine was. It was protein deficiency. And this Assistant Secretary of State kept calling it endema. And we kept saying, "No, sir, it's edema." "Oh, yeah. He got to Congress and endema. But, and then Kissinger became secretary.
I want to drop back also into the program, to the smallpox program, to see if there is any other event that springs to your mind, like the 25th vaccination that you, 25th millionth vaccination that you were involved in.
Well, as part of that, we went to a village in Africa, in Nigeria, for the 10 millionth vaccination there. And we got there, and there was the Timmy of 80. It was the chief of the village, and he had his leopard skin cap on and robes. And he went out into the town square, and here's everybody gathered around, and he gets up and gives the most erudite history of smallpox in Nigeria, back into early days of colonialism and so on. It was beautiful. We were sitting there. And then we went in to his house, and here was a plaque that said Honorary Kentucky Colonel, another plaque that said Honorary Alumnus of Western Michigan University. And I said, "Excuse me, sir, but tell me about that." He said, "I'm an expert in the talking drums, and the State Department takes me to the United States to give lectures on the talking drums, and they made me an honorary alumnus here." We said, "Talking drums?" He said, "Oh, yes." He said, "The drums talk." He said, "They don't talk in code. They talk in Yoruba." Yeah. And he said, "Would you like a demonstration?" He said, "I always keep a drummer out in the courtyard across from my house in the morning, and he'll tell me what's going on in the village on the drums." Yeah. So he said to his drummer, "Go across." And then somebody said, the drummer was in the house, and there was a man across the way. And somebody said, it was one of the AID people, said, "Have him come in and bow to the Timmy and throw the cat out." So the drum goes pounding away, and this guy comes running across, bows to the Timmy, picks the cat up, throws it out. I said, "Put up job." And he said, "All right, you do it." I was smoking in those days, so I said, "Tell the man to come take cigarette out of my pocket and light it. Pounds the drum. This guy comes in, counts 1, 2, 3, 4 to me, reaches in my pocket, takes out a cigarette, puts it in my mouth, reaches into his robes and pulls out a lighter. Well, he said, you know, it's true. We speak in syllables. So the drum has a head that you squeeze the side of it and it changes the tone. And Millar said, he said, but it has trouble with English words. And Don Millar said, how would it say Dr. Millar? He said, oh, that's Yoruba. Dokitor Millar. And that drum began going, Dokitor Millar, Dokitor Millar. You could hear it. And Bill Fagey says, you know, he was known as the tallest man in Africa. And the drums would pound out when he was coming to a village, the tallest man in Africa is coming. So, you know, that was an experience.
What else did you learn about Africa in the program?
What did I learn about Africa? Oh my goodness. In those days, it was a wonderful, wonderful part of the world, and that there was a lot of concern about improvement. They were interested. They were not as highly politicized as they are now. You'd get outside the capital city. They were wonderful people who were shaking off of colonialism. You know, one of the things in the West African program is that there were two very distinct parts of Africa, Francophone Africa and Anglophone Africa, and very different systems. The French actually were much better organized than the English. The English just picked up and left. The French left things behind and left some Frenchmen behind too. And they pretty much controlled the currency and communications and so on. What did I learn about Africa? I've never really thought of it in that terms, but
let me change the question then. You may come back to this, but what did Africa learn about the U.S. and the CDC?
Thank you. One day in the World Health Assembly in 1969, I think, the Minister of Health of Mali, which had been this Chinese Marxist country, got up, every country got up and made a speech in the assembly. This man got up and he said, I want to thank the United States for giving us assistance in our smallpox eradication program. But it wasn't the vaccine or the machinery or the jeeps, it was the people that the United States sent to help us. And that to me was, you know, that was sort of the crowning glory of it, that it was recognized that it was people rather than things. And we had sent to Africa young guys and gals who had had no experience in diplomacy, who had no experience with politics and so on. And they went out altruistic, but wanting to get a job done. We got a job, let's go do it. We can't do it ourselves. We've got to get the people in Africa to do it. We'll be there to stand behind them and push. We'll give them the tools, we'll give them the know-how, but they've got to do it. And they did it.
Fascinating. I have just a few more questions. I know that in the middle of the West African project, some people recommended that smallpox vaccinations be stopped in the United States, and that this became a hot topic of discussion at the CDC. Would you comment on that?
Actually, a little after the West African program, because it was by 1972 that we really came to the feeling that we could safely stop smallpox. There had been enough of the eradication program, not only in Africa but in other parts. India was going down and so on. And the risk of importation was so slight that the risks of continuing vaccination with the adverse reactions that you see with smallpox vaccine, the risks of importation was so slight that the risks of vaccination um, far exceeded it. So we had, as usual, we had a committee. We had our immunization advisory committee meet. We went over all of this, and we met on a Saturday morning, and I had been with the medical officer of health of Great Britain a few weeks before that, George Godber, and asked George if he would like to come to our meeting, and he said he would very much like to. And George was a fascinating person. He was the architect of the National Health Service in England. Ruddy-faced, white hair, monocle. He had lost this eye, and he said, why spend money on 2 lenses? I only need 1. And he kept the handkerchief up in his sleeve, you know, to pull out and wipe his eye. Typical, but articulate, out of this world. He was a beautiful writer and speaker. And we were struggling with the wording of our recommendation on smallpox vaccination. And George finally said, Dave, excuse me, this is your country, but it is my language. So that took care of writing the vaccination.
If you were going to start the program over again, would you change anything about how the smallpox
No.
was? Not a thing.
Not a thing.
That answers that.
As long as I could have the people.
How did the program change your career at the CDC? What impact did it have?
Oh, it changed CDC, and as part of CDC, it changed my career. What it really did was push CDC into the international, the global thing. It was really the first time that we had something from the inception. We inherited the malaria program, but this was a CDC operation, and this really was the beginning of CDC's continuing global involvement of not just ideas and equipment, but people. We put people with in Dhaka at the old cholera lab. We started the field epidemiology training programs in different countries. You know, it just goes on and on and on. And so I think that, you know, you grow with it, with the organization. The organization doesn't, you don't pull the organization pulls you.
Did the smallpox program per se, since you were here at headquarters, did it have any impact on your family?
Not as much as it did, because I did a lot more traveling, but I was not a traveling salesman just home on the weekend, but I had to travel a lot. It became worse with traveling to Washington, but I think my family were envious of me going to Geneva for 2 or 3 weeks every year to the assembly and things like that. But I don't think it had any great impact on the family.
But I do believe that all 3 of your children are in the field of health in one way or another. Am I right?
Yeah.
Yes.
Our oldest daughter is a pediatric oncologist. Our middle daughter is a nurse practitioner in oncology, and our son's a deputy general counsel at Emory, but he handles a lot of the research and intellectual property sorts of things there.
Before we stop, is there anything else that I've missed that you'd like to add?
I'm tired.
Oh, well, I thank you very much for speaking with me, and I think this gets us off to a wonderful start for these
Thanks.
recollections.
Yep. And I would like to thank Brian and Lee.